Hi, and I'm going to go do it with a little bit of help from Martin. So when we get to the questions bit, I'm not on my own because I don't think I have the ability to read, think, and speak. So Martin's going to help me. I'm really, really pleased to be here to talk about some of the work that we've been doing. I was reading the little brief and I was thinking, oh, I wasn't quite sure that was what I was here to do today. But we've done a lot of work in general practice. So some of the stories will be from general practice. But the work that we do is about a way of working, a way of being. So I think I might need to ask you to think about, so what does that mean for us? So the work that we do, in terms of the context in which we're working, some of this stuff has been, Martin talked about earlier. We're working at the moment in the NHS in a system where there are lots of new demands on the service, on all parts of the service. So the area that we're particularly interested in is the things that people are presenting with but are not being met. So we're interested in the fact that there is an increased demand, but it's not by more people, it's by people who keep representing. So there's an increase in failure demand. And that's a real concern if people come back and we're not paying attention to what we do about that. So a lot of our work is about thinking about how we respond to the demand. We know that a huge cost in the NHS is failure demand, so people just keep coming back, but their needs are not being met. Much of our work is in general practice, and we talked to a practice in Dorset not many weeks ago, and they looked at their data, and one of the people on their list had come to the practice 148 times in the year. There was no single health condition. There was no secondary referral. And the practice were horrified. They were horrified because they hadn't met that need. And they were horrified because that person had taken up, in effect, 3 appointments per week. So that's probably not the thing that matters most to you in terms of your services, but there's something around thinking about how people use your service, whether their needs are met, whether you even know that. So I think it's about thinking about how you respond. So we believe that the solution around the problems that are now beginning to present in terms of people with multiple long-term conditions, people who are presenting, who are not coping, who are not managing, who are not adapting, we don't think that the fix for those problems are technical fixes. We think that they're problems that other people might help with. And our work is about inviting people who are not medical professionals to work alongside us to try to make a difference. The work that we do, so we have worked over the years, since about 2008, with more than 25,000 people. Patients, people in communities who come forward to give their time to work alongside services to make a difference. And I love what Jerry said about purpose. They have the same purpose. Their purpose is to make a difference to the lives of other people in their community or people like them. So we've got young people in Shropshire who are working with other young people to make life better for young people. We've got people with diabetes who are working with other people with diabetes around how you have better outcomes, how you have a better life, actually, not better outcomes. And what we found a sustainable way of working, because when people come forward and they become part of a relationship with the people who are delivering services. So what we think that we found is a sustainable solution. So this is not something that will need continual funding as we go on. And that the success of the work that we do lies in the whole. So people come together and they work as a whole system. So this is not about giving jobs to people. It's not volunteering. It's not about deciding that what we need is drivers or what we need are peer educators or what we need. We bring people in together and we work out as a system what it is that we'll design and do together that will make a difference. The work is about actually developing a whole new way of being. So it's quite a challenge to health services to operate in a different kind of way. And I'll share some of the challenges that we've had. But what we think this is about, it's about the future. And I was thinking again about our purpose in Altogether Better. So I haven't actually said we are an NHS organisation. We work around the country. Our purpose is to save the NHS. That's my purpose. That's why I get up in the morning. I think that if we don't do things differently, we're going to lose the thing that's most precious to us. So I am absolutely clear about our purpose. what were the other things Jerry said? So that was the why. The how is that we do it in relationship together. So we invite people in. That's what's unique about us. We don't exclude anybody. Everybody's part of working out what matters, what data we collect, what we're going to work on, how we're going to deliver it, what we're going to do. And then the what, we do what matters. We do what matters in that place, in that space, to that group of people. And when people get behind it, then we really see some change. This is a slide produced by, so I talked about the things why we do it in terms of the health system and the context that we're in. This is a slide that was produced by a woman called Sarah Regara, and she has Parkinson's disease. And she said all of those little blue pixels are the hours in Sarah's year. And she says that the little red dot is the 1 hour that she spends in healthcare with the people who support her to manage her Parkinson's disease. And the other 8,765 hours Sarah spends in self-care, managing this really difficult condition on her own with a GP. And one of the things that's really, I noted was we've got one GP in the room. Well, given that ratio of 8,765 hours on her own, 1 hour with the neurologist, I think there's something about what do we need to do together, who's missing in the room, who do we need more of if we're going to really support Sarah to look after her own health. We've also picked up on the Huber definition of health, which we find really helpful in what we do, and really helpful in terms of the context that we're operating in. So she talks about health being the ability to adapt and self-manage in the face of social, physical, and emotional challenges. So this is about how do we support people whose condition will change. They have to learn to cope. Things will change again. They have to adapt. They have to keep on going. They don't know where it's going to go. They don't know the trajectory. So I think this is really helpful in terms of how we might think about responding to the issues. So the question that we need to ask ourselves, we believe, is how do we support people to adapt and change in the face of the challenges that they're presented with. And we also think that systems will organize around a purpose, as Jerry said. If we want to change the system, and we think the system needs to be changed because it's a medical model, we need to agree a new purpose, and then we need to think about who's in the room when we agree the purpose. So I don't think, just for medics, for doctors, for clinicians to decide what that purpose is, isn't going to do it. If we're thinking holistically, if we're thinking about trying to do something different. So what we've done is we've worked over the years and developed a new model of working that we've called collaborative practice. We've developed the model in over 150 GP practices around the country in 24 CCGs, and we've learned such a lot. We've also done this work with regional specialist hospital services with people with ME and chronic fatigue, done some work in A&E, done some work with children. What's really important about this is that citizens, patients, people with MS, families of people, they're absolutely critical and pivotal to the work. So that we don't consult with people. They are core to the work. They're central to everything that happens. And what we've done is we've changed the conversation that we have by changing who's in the conversation. In that conversation, we've done a lot of work. We were big lottery funded, and when you're lottery funded, you get lots of money to evaluate. So we invested about £500,000 in evaluation of the work that we do, in publishing the work that we do, so you can find it on the website. Lots of lessons learned, but this is really about finding a new way of doing things. Gavin introduced me and said this was about empowering people. Years ago, we used to talk about empowering people. We don't say that anymore. It almost feels like it's rude to me now to talk about empowering people, because it's not my gift to give. People come, actually we do more to disempower people in the NHS. When I had my first baby, I had never held a baby before, and they wouldn't let me carry him around the ward. in case I dropped him. Can you imagine how I felt when I left? I just felt like I must be the worst person in the world. I'm really not fit to be a mother because he wouldn't let me carry him because of the risk. And I was told I couldn't carry him because of the risk. And when I left to take him home, the midwife carried him out in a baby car seat because he couldn't trust me to do it. How disempowered was I? It was bad enough that I'd never held a new baby, but then to be told I could only lift him from this little box and put him back in this little box, I was absolutely terrified. I cried all the way home. So it's something about this whole notion of empowering people. People are already empowered, and the 25,000 people who've stepped forward to work with us would think it was rude if I talked about empowering them. What we have to do is actually begin to find ways to see people as partners, as equals, as people who bring something we don't bring. So I just went back to that one, but I think if you look at the data that we've got the evidence for the work. There's lots of international data around working with people, around co-production. The work is about creating a health service fit for the future. So it's new. It's people who step forward to do this work are leaders, are pioneers, are people who want to try and do something differently. The old world bites back quite hard a lot of the times. So it's people who are brave enough to do that. So our work involves supporting local services, whoever they may be, GP practices, hospital departments, to invite local people to work alongside them. To make a difference to what they do. And I use the word invite. We don't recruit people. You recruit people to jobs. You recruit people to the army. You don't recruit people to give something to you. So I wouldn't recruit you to give me gifts. Well, it might be quite nice to do that, but I would invite you to be with me and to give your time to me. So there's something in the language that's really important in this work. We also start with the data, so that was something else Jerry talked about. We think it's really important that health services understand the data that they've got. In general practice, people are not used to looking at the data. They collect it for the purpose of payment and for CCGs, but not to actually use it. So we're beginning to get people to really think about what the data tells them. Who's using the service? Why do they use the service? What are they coming to us for? We've been having some really interesting conversation with Gavin and the team at Barts, and we were just the language of a follow-up appointment. What is a follow-up appointment? What does that mean if you're a person with MS? It doesn't mean anything really. So thinking about what is the purpose of an appointment, why, what do people need to get from that, and how do we think about how we change language in order to change what we do. So citizens come forward to work alongside a service, and what you end up with is an extended team of people. So we've done, as I said at the beginning, we've done lots of work in general practice. We've got the first practice that we worked with was in Leeds, in Pudsey, and it was in 2011. Today, they have 60 active practice health champions, that's what we call them. They work alongside the practice. Every week, they deliver 40 weekly activities. So it could be singing for the brain, it could be computer club, it could be job club, it could be poetry in a pint. They work with the practice, and because they're part of the practice, they change who the practice team are. They start to do things differently. They're the only practice in the country that I know that has a licensed bar, and they're the best place in Leeds to buy cake. They're also a practice that has increased their list size by 4,500 patients, and they have no more primary or secondary care appointments because people have taken a step to the left. So people are doing other things other than coming only for appointment. So when they ring the practice, they don't ring for an appointment, they ring to have a need met, and people would work out what was on offer. So there's something about what do people present to MS services with? Is there a way to look at how we might do it differently? So we look at what it means to have a new extended team of people who would work together, and we look at how clinicians can connect people to things that happen outside of the service or outside of the practice that would meet some of those wider needs. So in general practice, what we found is it changes the business model. Because it impacts on failure demand, it reduces failure demand. So we've seen a reduction in the number of people who use the service. We've also seen list size grow. but without having that extra cost. So we see GPs at practices where they see just 12 patients in a morning instead of 15, so we can change the flow of how people use services. And that's really, really important. But what it's also done is it's increased the list size, so it's not that the quality's gone down, the quality's improved. And in this particular practice, they don't see the frequent attenders all of the time, and they have less appointments, but the people they do see are more tricky clinical cases, so they put a 45-minute break in mid-morning so that they have coffee together, the GPs, and they discuss difficult clinical cases. This is about improving quality. And one of the things that we heard when we were doing some work with Gavin, we talked to people with MS, and one of the things they told us was that they wanted to be able to get better services from general practice. So I think there's something around how do we work alongside general practice as partner with a stake in this work to do things differently, and how do we free up their time so that they can do that. So what happens when we invite people to work with us as part of a different service offer? It changes the culture because it changes who's in the service. My best example to understand this is I have 3 grown-up sons. They're 26, 22, and 20. And you can guess everything about me and my family. You can guess how much I know about Liverpool. You can guess, because we're interested in it because of who we are. So the flow of information into the house, the things that we watch on the TV, the films I see, the state of my porch, all those things are about having a family with 3 boys. My dream is that if there were girls in my family, if there were other people in my family, we would be doing totally different things. I certainly wouldn't be watching as many sci-fi films. And that's what happens in general practice. So if you change who is a part of your team, you will change everything about your team. You'll change how you see the world, the things that you do, the things that you care about because of who you are. What this also does is it transforms lives. This makes people's lives better. And it doesn't take very much. Martin talked about, changing the DNA of the bird. Was it bird? Yeah. It's a really small change. General practice is really good, but it's a small change. And I think it's the same in terms of other services. It's not about saying services are not good. It's about saying what can we do to adapt and to cope and to do things differently. So in terms of how we work, we've developed some simple tools to help people collect data that helps to underpin the work. And that's about really understanding what people present with. Are people presenting to you for the right reasons? Can we understand that better? We can help services to invite people to become part of that extended team, and there are ways to do that, and we've learned ways not to do that. My best example in terms of inviting people, we put out an invitation in a GP practice in Stockport one Wednesday, and a week later 600 people had responded. 600 people who said, how can we help? And when we asked them, why did you come forward? They said, we felt honoured to be asked, we felt privileged to be asked, because they love general practice. They want to do something differently. And we asked people with MS to come and have conversations with us, and they came and they gave us their time, and they had so many ideas and lots to offer, and they have a way of seeing the world that we don't see through same eyes. So we invite people to come forward. We can help people to have good conversations, and the purpose of that is to build relationship. And then we can guide and mentor and support staff in operating in a different way, because staff are not used to being in a working relationship with people that isn't dependent on the hierarchy. So it's easy to fall into the language of management and supervision, but you don't manage and supervise somebody who's given you a gift. You have to find a different way of being, but we can help people to do that. And we support the staff, so we work with a circle of staff that will then take those citizens in as part of that broader team and help them to work in that new relationship, because it's different. But when people do that, amazing things happen. this is just a slide about the data. So one of the things that and I think this will be different with your service, and we would have to think about what this means for you. But in general practice, we look at the top 100 people who use services in the GP practice, and we ask what they're using services for. And it's a really small percentage of people use the service very, very frequently. So instead of making a universal offer to everybody to try to make a change happen that we want to happen, we focus it on those people who are attending all of the time. And when that happens, we can see some really big changes. We look at the motivators for general practice. One of the motivators is the cost of people who are attending frequently, whose needs are not being met. And they can see that if they put their efforts into a particular place, they can really change what happens. We also find, and I think this is transferable to your services, that there are lots of assumptions about what happens and why people come and what people present with. And in the heads, most people's heads, they think it's people with multiple long-term conditions who are over 65. It's not. So 50% of them are people who are younger, typically, range of different people. And when they begin to go through the list of folks, then they're beginning to understand that they need to do something differently. And I think the purpose also of collecting the data is to have the conversation, so the clinicians will sit down together, they will talk about who's presenting, whether that person's needs are being met, what other things could happen to do things differently. So a GP colleague of ours in Exeter for 2 weeks just looked at what came through the door in terms of what people were presenting with. So between 40 and 55% of people were presenting with a non-medical need, a non-clinical need. And that'd be a really interesting question to ask you. How many, in terms of what matters to people, how much of it falls into those other areas? So people were presenting with minor ailments, people were not coping, they were depressed, anxious, tired, there were some lifestyle-related issues. But in general practice, we know GPs are not the best people to help say. So weight gain might be one of them. The research tells us that if GPs suggest people lose weight, on average, people will put on 2 pounds a year. Because weight is a social thing. There's nothing I don't know the calorific value of. So I have information, I have knowledge. That's not what makes me take the next piece of cake or not. If I tell my sister she gives me the look, that's what will make me eat or not eat. And much of what happens in health is social. It's not about knowledge and information. A category of the people that Neil saw were just lonely. So in terms of the people that you're working with, these people who are at home, people who are not connected, people who are no longer working, what does it mean? What does this data mean for you? What would it look like if we collected something similar? A number of people just getting older. The service actually can't do anything for those people anymore. But the NHS is not in the business of saying, no, we're not going to help you. So what is that going to look like? And then the dark blue quadrant is the people who were coming with a clinical need. But what that shows, but general practice is all organised around the clinical appointment. It isn't at all organised around that other 40 to 55%. So I think the question for you would be, what do people present with? When do people come? Are appointments worthwhile? Are any appointments wasted? Do people get to see you when they really need you? Or do they just have a routine follow-up that they come to, but on that day they might be feeling great, and it's great to say, I'm feeling great today, because if you're poorly a lot of the time, they might not want to go into what is happening the rest of the time. So I think there's something really interesting about how can you use data to think about your services differently, and that's where the work lies. So I talked about inviting local people, and we have no difficulty getting people to come forward. When we invite people, we invite them to work with us. So we bring them into the room. To be part of one conversation. So this is a meeting that we had with clinicians and with people with MS at Barts a few weeks ago. Fantastically enthusiastic people coming forward together. So a mixture of people, researchers, academics, educationalists, clinicians, nurses, doctors, whole range of people, and people with MS, and their families, and their carers. And the richness of the conversation was absolutely fabulous. It was about deciding together what matters to those people. And I think the thing about resources, we often find that when there's money, it's a disincentive. When there's no money and you can only do it with the resourcefulness that you have in the group between you, that's when really exciting things happen. And I have a great story about resourcefulness. A practice in Gateshead were running a tea dance. No, they weren't running a tea dance. They wanted to do something for people with long-term conditions. And that sounds really dull to me. You know, what kind of thing, like, great, I'm going to an afternoon for people with long-term conditions. It doesn't really have the draw that you would expect. So they asked the champions in the practice, what can we do? This is, you know, and they said, well, how old are the people? And they said, well, a lot of these people are older. Champions said older people quite like to dance, so they thought they would organise a dance. So they had no resource, but one of the people in the group used to work for the local authority before she went off sick, and she said, I can find us a room. So she found a room big enough to dance in, and then they thought, well, how else do we get a bit of pull to get people to come? So they gave the most handsome GP and the most well-loved GP in the practice a dance card, and more than 250 people came. So I think there's something about money, and there's something about creativity, and there's something about doing things that are fun. And one of the things our research told us was people will only do this work, not just citizens, but professionals, if it's both meaningful and has purpose, and it's fun. If it ceases to be fun, we stop. We start to sabotage. We drift away. We stop being part of the network. If it's a network that works, we need to be willing to be in relationship and be together and to have fun. And that practice has gone, that's another practice that's done amazing things in terms of its list. So we just looked at their data. We started to work with them in 2014. They've reduced their attendance by 30%. It's massive. So GPs go home at 4:30 and 6:30. It's a completely changed their way of working. So we bring people together in a workshop in conversation, and out of that conversation come ideas that they're really unique to the people in the room and what matters in that local area. So every place will be different. Your situation will be different. We asked people with chronic fatigue what mattered to them, and they said that they were tired of being tired. And so they did things that were around what that meant for them. And they said, we want to be able to go out with our friends without having to explain every time why we can't come this time, and being afraid that we'll not be asked next time. And so they organised social things together so that they didn't have to go through that whole rigmarole. They also did a lot of work around, as soon as they came to work with it was a regional specialist service in Newcastle, so it covered the northeast. As soon as they started to work alongside them, the service was threatened, it was going to be chopped, and they said, this is the first time anybody's ever believed us, and that we've got to this specialist service. And so what they ended up doing was, they ended up campaigning to keep the service from being taken away. And the group of people, there were a really fabulous group, mostly young women. There were musicians, there were artists, there were poets, and they ended up with a breakfast television campaign. They were on the radio, they wrote things, they managed to get themselves in the media because that was their skills. The service couldn't have done that. People in the service didn't have time in their day job to do that work. So it's about what resource do people bring. So back to the thing about empowerment, we certainly weren't empowering those young women. They were brought more than enough confidence, enthusiasm, gifts that the service didn't have. So I think it's about seeing people as partners. But out of the workshop come ideas, so people begin to turn ideas into action. In general practice, it looks like some of these things. So this is one practice, actually. They have an allotment. Auntie Burnham came and opened it a few weeks ago. Nothing in the allotment they didn't have any money for. They just went and asked people. So they asked people with diggers to come and flatten the site. They asked people with soil to donate soil. They ended up with a whole range of things. And they've got an allotment now. They set up a singing group. There's standing room only at the singing group on a Wednesday. And Florence, who was this practice's #1 most frequent attender, she goes to the singing group. She doesn't go to practice anymore. She takes cakes for the girls on reception because she misses them. But she's found something else to do. So how do we support people to live, cope, manage, and adapt? For Florence, she's found that way through doing things with other people. She has got a complaint, actually. So we introduced her, one of the champions introduced her to 3 other women, and she said the trouble with them is that they're poorly. All they ever talk about is being poorly. And this is Florence, who was the #1 most frequent attender there 2, 3 times a week. So it completely changes how people feel about themselves. But the other thing about it, apart from whether or not she uses services, she feels better. She's having a life. She's having a really nice life. So it's a completely new way of being for Florence. The picture on the bottom left, that's Catherine, the nurse. It was snowing last winter, and she was having to do home visits, park the car, find somewhere. It was taking twice as long. Dave took her round so that he waited outside of every house, so she didn't have to park up in the snow and walk. Now he does it every week because he just enjoys it, gets him out of the house. He's also dying. He has cancer, and him and his wife are champions. But he knows that she's going to be okay when he goes because she's part of groups. So this is about belonging. This is about being in relationship. This is about... And he just says this keeps him going. This is something that gives him purpose, gives him meaning. And he feels better than he could have felt if he wasn't giving. And I think this is something around... We've learned people don't want to be helped. They want to be part of that solution. They don't want to be. And in the NHS, we give to people, we serve people. What this work is about is inviting people to be partners to do it with us. So, in some places, this doesn't work. And we really struggled with it in the acute service. And we worked alongside some linguistic analysts to help us understand why it worked in some places and why it didn't work in others. And they recorded lots and lots of conversations. And they came back to us and they said that they found in the language, when they analysed the language fell into either one of the 2 worldviews. So the formal system worldview, you'll recognise all of those things. So this is a worldview where the language and behaviours, they're full of language around roles, qualifications, titles, job descriptions. It's about process, structure, data. We get paid to do the jobs we do. We might not think they're the right things to do, but we get paid, so we do them. So it's about following protocols. It's about pathways. It's about strategy. It's about long-term plans. The other world, so some people's language and ways of being felt real, that was where their preference lay. The life worldview is a really different worldview. It's where people come together in relationship. They do things for each other because they're in relationship, not because they're paid. So, we're in relationship in a family. I'm not paid to empty the dishwasher or make the beds, but I still do it. In the life world, we have lots of identities. So I'm a sister, I'm a mum, I'm a friend, I'm the director of Altogether Better. Multiple identities. In work, we wear one hat. In the life world, we wear many. What happens in the life world is that we tell stories. We don't use data. So I know the data about calories and food. I don't take a lot of notice. Something different about in the life world, it's about stories. We share stories with each other. We're in relationship. We don't do it for reward. And the other really significant thing is about emergent order. So I don't know about you, but in my house, we don't know what's going to happen after tea, never mind in 5 years' time. Unless there's a football game on the television, then we definitely know what's going to happen after tea. But so when this worked really well, it happened in a place in the middle. And they called that place in the middle liminal space. So it's the place between 2 worlds. They said, think of the beach. So the beach lies between the land and the sea. Land and the sea have their purposes. They're both good. It's not about saying one's good, one's bad, but the beach is different. there are some risks. There are also some possibilities. Lots of fun things happen on the beach, but it's definitely different. But we understand the rules of the beach, so we rarely get off the, past the ice cream van in our bikinis because that's for the beach. So something about understanding what the rules are, and this work, for it to work really well, people need to understand what those conditions are. So there was one practice where a practice manager who really wanted to make this work, we had 20 champions who turned up to be part of the workshop, and just after the workshop he gave them a code of conduct. And the code of conduct says, these are the rules, you're allowed to use the toilets. If you break the rules, we will strip you of your health champion status and legal action could be taken. So within about 3 minutes, Elliot went from 20 champions to about 3. People do not, if I invited you to help me do the decorating at home and I gave you a code of conduct, you'd be out of there. You wouldn't stay. If you came to help me do the decorating, you'd get really good coffee. I'd introduce you to my boys. If they weren't well behaved, they'd know about it. So I'd hold them to account. I'd introduce you to everybody else. I'd ask you what you like to do in terms of the decorating. I wouldn't tell you what to do. There would be a totally different way of being. So what we have to do is to find the way of working that works for people. I think it depends. It's about people having a willingness to want to find that. But the services that we work with who have found that, they've completely changed their services. They've connected people to new offers, so not just the medical offers, but other offers, the social offers that people need in order to have a whole life. So when we asked people with MS what mattered to them, it was about being connected to other people. It was about having access to be able to do the things in their life that they wanted to do. It wasn't the same list as the clinicians came up with. So I think we have to find ways that we can connect people to the things that you don't offer. What you offer is just one part of it. So I'm almost there, I'll finish. So some people call this volunteering. We don't think this is just about volunteering. Many of the volunteering programs are about giving people jobs to do. This is about inviting people forward to help you to design and do things differently and to deliver things differently. And other people have said, is this social prescribing? And I think it does all of the things that social prescribing does. So it invites people to come forward, they offer things, they deliver new offers and activities. They connect people to other things in the real world outside. But it's more than that. It's about change in organizations. It's about, I think this is gentle and subversive OD. It's about change from the inside. It's the boiling frog. It changes the service without them really feeling the pain. The water just gets slowly warmer and warmer, and they don't hop out. But it's something that we get to slowly. That was probably where it's best to stop, because I've taught for a really long time. So I'm hoping that Martin might have some questions.
I'll just show there was a questionnaire put out there to how many patients do you see that don't need clinical support? And 54% of the group have said between 25 and 50%. So it sounds like there's scope for a range of other offers within that. Yeah, that's the response up there. Okay. And then I'll go through the questions with you in a minute.
Okay.
Just.
So 12%. I'll leave it for a few minutes to people.
Yeah.
So has this just gone up?
No, it's been a bit while when you answered the question previously.
Okay.
From perspective. But we'll just let people vote now that are there.
Fabulous.
And whilst you're voting, I'll answer one of the questions that you put up just while it's doing. Someone had asked what we mean by failure demand. And failure demand, the evidence is both in social care and health care that 60% of the expenditure is failure demand, i.e. the costs of not meeting people's needs when they present. What does that mean in practical terms? GPs, you say, oh, you can only bring up one issue at a time, and you've got to come back with another 3 appointments. They're probably all connected, uses up a massive amount of care. Simpler examples are we doing work in Leeds around children and young people and families. When the mother comes, brings the child to see the GP, and the GP knows there's something wrong within the family dynamic, etc., but they've only got 10 minutes, they don't want to open that can of worms, and hey presto, that mum comes loads and loads of time. In Islington in North London, a child with child with a cow's milk protein allergy, on average, sees a GP 17 times before they get a referral to secondary care, because the GPs think all the first-time mums are just worried mums and ignore what they say. There's a whole lot of stuff around in secondary care as well. You know, as I was saying, 60% of the costs by analysis from Intermountain and the NHS, etc., is failure demand. We're not meeting people's needs when they present, and that generates vast amount of cost over the years and time. So, yeah, do you want to respond to the, just saying this? So I'll say, how do we get GPs interested in working with MS services to work more collaboratively to improve services?
I mean, I think we've got to have them in the room to be part of the conversation to find out why why it is the way it is at the moment. And I think that what we've learned from all of our work is that we can't know about other people. We have to have them in the room to be part of that conversation. And it's fabulous that we've got one GP here today, but we chatted it over coffee. But it's the GP who also has a particular interest in research, which is probably the reason why they're here today. But I think to know the answer to that question, we need to meet with GPs to find out.
Yeah, and I also think what happened, we found a really good way of getting in is simply pulling the data. So who have you got on your list who's got MS? What's the data of how often they've attended and why as a conversation? Have those people in. And of course, the future, there's incredible opportunities now with primary care networks, because all of a sudden there's genuine money available for GPs with special interests or to look over after a population of 40 to 70 odd thousand people, in which case the number of people with MS will be slightly higher, and people will move across practices. There might be one GP who specializes in MS across 5 or 6 practices. For their patient stays on the GP's list, but for the MS thing comes there. So there's all sorts of really, really exciting possibilities now. And we know that particularly with money and funding some of those roles from primary care networks, I think there's incredible excitement. But the key bit is get them in for conversations, pull out the data, and start to look at what's actually happening. And you'd be surprised at how most GPs don't want to be a bog standard GP 5 days a week. They just get, the pressure is horrible. So their curiosity and interest and openness to having other roles and specialties increased dramatically over the last decade.
One of the really interesting things that we found, I've just read the thing about it might seem counterintuitive to do this when you're so busy. One of the things that we found in general practice was, they said the same thing. They said, we're too busy to do this, or some practices said that. But what it does is it provides an authorising environment for this to happen. So needs need to be met. People will continue to present in general practice whether their needs are met or not, because there's nowhere else to go. So if the practice then says, how do we organise differently in order to respond to this thing that's presenting, then we can not divert, that's not the right language. We can help people to get to where they need to go. And I think it's the same for hospital services. If people are coming to you whose needs you're not going to be able to meet, rather than them keep coming back or them feeling that, I think there's something about resilience. The data told us that people are more resilient who are supported socially when they're connected to one another. We know that the people who come forward as champions, their health and well-being improves incredibly. So it might be those people who you feel that you can't help might be the people who are most likely ones to be invited to be involved, because once people have got that meaning and purpose, then that's an offer that you make them in terms of their well-being. And one practice manager in Gates said she only ever invites people to help who are either the people who complain the most or the people who are the poorly people. So the complainants, they come forward and she says, great, you've brought a complaint, help us sort it out. So she doesn't have to push back. She says, help us sort it. So I think there's just something around how you work alongside people. And the other thing that we found is this brings forward a group of people that you would not normally identify as volunteers. So we collect the demographic data from everybody. It's so varied, it's so wide. We've got people in work, out of work. We've got people, the youngest champion we've ever worked with is 11. The eldest is about 95. The real spectrum of people. We've got CQC inspectors, we've got ex-GPs, we've got people who've never had a job in their lives. They're absolutely incredible range of people. But what they do is they bring something that we never imagined that they might have to bring to offer. And I think there's something about, what I've learned about this is, in the NHS, we always talk about people. We think we know about people. We think that we can know what other people need. My best, one of the examples I've got around this is my eldest son came out of university, couldn't find a job, began to lose a bit of confidence. He'd done a history and politics degree, couldn't find anything. And we just happened to have a practice near us. So I suggested to him that he might go and become a practice health champion. And at first they didn't want him because he wasn't a patient. And that was a really interesting conversation. You know, I will take a gift from anybody. You don't have to be a member of my family to give me a gift. But they seem to think that the person had to be in relationship as patient in order to volunteer. Anyway, James said, I'll be a patient, because he hadn't registered with the practice after having come back. So he went through all the things. And then they said, no, you can't be a patient, because he lived outside of the boundary. So he came home and he said, I can't get a job. They won't take me as a volunteer, and they won't even have me as a patient. And that's the NHS's response to somebody who wants to give them a gift. So we did have conversations with them, as we would, and they decided that they would take him after all. And then I got really worried, because I thought, oh my goodness, what will James offer to this practice? What is his lived experience? What's he going to bring? Because people bring all sorts of stuff. And he's 21, and he spends all of his time on a PlayStation in the bedroom. I think that's what he's doing. And that just crossed my mind and came out. Anyway, so what he did was, he said to me, he had an idea and said, what do you think? And honestly, I was utterly, utterly humbled. He said, what I'd like to do is set up, not a group, but just meet with kids, one or two kids in this local secondary school who stammer, because my son has a stammer. And he said, the speech therapist can help me form the words, and you can love me when I'm being bullied, and, you know, be sympathetic when I can't get a job, I can't volunteer, I can't even be a patient. But nobody knows what it's like to live with a stammer other than somebody else. And so that's what he did, and I think there's something for me around, you cannot know what people will bring, so you can't predict what will happen. You can't say, we'll have a piece of work that will do this, this, and this. So what his gift was amazing. And then the other thing, because I'm a busybody, I said to him, well, if you're going to meet with other young people, make sure you meet where young people like to meet. Because I think I know all about young people, because I've got 3 of my own. So I said, you know, like Costa, because we know young people don't like clinical surroundings. And he said, Mum, that would be the worst place in the world to meet. Because if you had a stammer, you wouldn't want your mates to see it in Costa with other people who had a stammer. So he said to me, you go somewhere young people never go. So I decided I knew nothing about young people. And said, so okay then, where would young people not go? And he said, the library. So I think this is really not about, it's doing things for people. It's not doing things where we think will benefit people, but actually him being central to be part of what that would look like, and us being able to trust and see people as equals, not think that we're empowering them to give, because actually what he's got is more than I've got. So I think I know this work, and he proved to me I don't. It proved to me that I have to listen. It proved to me that I have to see him as of equal value. It doesn't have to be hugely knowledgeable. He just knows what it's like to be a young person. So,
and just to patients to see a clinic at request and regular follow-up appointments. Again, every service is different, every patient is different, but the evidence is overwhelmingly like that. And the best example was started 10, 15 years ago at Northwick Park. Breast cancer survived. That after women had breast cancer, they had routine follow-up appointments. And it turns out, according to the oncologists we work with, no one has ever rediscovered a recurrence of breast cancer in a routine follow-up appointment. So they cancelled them all and said, this is how you check, and if you've had breast cancer, you're very good at checking. They guarantee within 48 hours of a phone call, you would have an appointment where you'd have every test and see a consultant. Women are delighted with the service, the workload for the consultants has changed dramatically, etc. This idea of routine follow-ups is complete madness. I think what our work shows, and we run lots of sessions with patients and their clinicians, etc. What most clinicians don't realize is that most patients lie to their clinician most of the time. about their medications, what they're doing. So this builds a completely different relationship that gets far more honest, that citizens start taking shared responsibility for what they need to do. But we've had rooms, 20 patients, their clinicians in the room together, working separately. All 20 said we're lying about our patients, etc. Because the conditions they need is, how do you have honest conversations? How do you do negotiations? How do you tell them truth, how you're experimenting with the medication? But no one's taught them how to experiment, so they're actually not really doing it very, very well, etc. This builds a completely different set of relationship. People want to be seen when they want to be seen, not just because it's a routine appointment booked umpteen times in advance. And it's madness from their perspective.
I think there's also something about, one of the examples that comes into my head, my husband's a type 1 insulin-dependent diabetic, and he's had it since he was 16, he's 59, and until a few years ago, he hadn't met anybody with diabetes, and they offered him a Daphne course, so he went along onto the Daphne course, but there was nothing that it could teach him, because he spends all of his time on the internet, and he researches everything. So in terms of what Daphne was about, didn't teach him a great deal, but meeting other people was absolutely fabulous, and the NHS had been trying to get him to use a pump, and he wouldn't use the pump because he'd heard about the wires, and he wasn't keen on it, and he thought it would be a problem because he does lots of sport. He talked to other people in the coffee break, just in the little bit of coffee break, and in that little bit of time, they shared with him what actually it really is like to live with a pump, and so he changed. And it just struck me that for every appointment that he went to, that was the conversation, trying to get him onto the pump. And he said, there must be something in it for them, because that's all they're interested to talk to me about, using the pump. Now he uses the pump, he knows why. He's so much better than he was before he was off it, but he hadn't really understood it. And then the other example I've got is that he has this 1 hour long appointment with an endocrinologist and the nurse, and they got him to change to a faster acting insulin. And they did, and it was a really fabulous appointment. It didn't used to be like this, but they worked it out together. But he set off to do it over a weekend, and there was nobody to call. And what we realized was missing was another person with diabetes who had gone from onto this new fast-acting insulin. If he had talked to somebody, I think he could have stuck it. And he thinks he could have stuck to it. But there's something around. If the NHS is willing to put that amount of resource, clinical resource in, why could somebody who had got experience of that not be part of that group of people? It was a three-way conversation, and what I loved about it is this started with the data. So the conversation between the three of them started with, this is what the data is telling us about your blood sugar monitoring over the last 3 months, and because it's got continuous blood sugar monitoring. But I think if we had a person with diabetes in that group of people, it would have been a totally different outcome. So I think there's so many, many different possibilities. I want to pick up the one about how do we cross the divide between CCG and NHS England Commission services and get them to work collaboratively on services for people. I think people in NHS England and in the CCGs are really interested in this. And if we get people involved at the beginning of a conversation, rather than trying to persuade them of something that we think is a good idea at the end, that we'll take them with us. So we are talking to people in NHS England regularly, all of the time, about our work. And sometimes we know that it's better that they don't get involved, because they might actually ruin it. There might be things that inadvertently, not because they set out to do that, but as soon as they decide that something maybe needs to go into the contract, it might pervert it. It's the thing about metrics. If they design the metrics, it might not be the metrics that matter. And that reminds me something about metrics, which I just wanted to share. So we were looking at how would we know if this worked in a practice or in any setting. So we talked to the group of people about what metrics we would have, and we decided it would be how many cups of tea or coffee champions made in the staff tea room. Because that would be an indicator, a metric that told us something about how much they belonged. Because if this work is about relationship, it's about belonging. It's not about being served cups of tea by the staff in the practice who treat you as a guest. It's about being part of that extended team of people. So that was a metric that mattered, but you would never get NHS England coming up with a metric like that. So I think there's just something about how we work with them, and that we bring them on board early enough to help and to design the whole of it, not just part of it.
And there was a whole exchange around general practice and MS services, and there's clearly some experience in the room of really good experience of building relationships with GPs that whoever put up the anonymous thing should probably also share and allow. There's something about patient activation measures, assessing patients' ability to self-refer, aside from the language of patient activation, because if we talked about activating clinicians, you'd all be hopping mad. Again, the suggestion is really easy. Just prototype it. Wherever we've done it, wherever we've allowed open access, that anyone can refer to anyone. So there's places we've allowed social workers to refer directly to secondary care. All you do is close the feedback loop. Overwhelmingly, they refer better than GPs do. Because people take their responsibility so seriously. And all you have to do is close the feedback loop. If you're saying that I need to self-refer for a secondary care, to see a specialist, and it turns out not to be appropriate, just close the feedback loop. You have the conversation with them, it doesn't happen. But overwhelmingly, self-referral works brilliantly, particularly with a focused patient. It's not for a first time. It's terrible for a first-time appointment. But when you're in a relationship with them, when they're your existing patients, saying, when you just call us when you need us, the evidence appears to show it works brilliantly. Never for a first time on things, only with people you're in relationship with. They've got something around why do trust CCGs encourage neurologists to discharge patients with long-term conditions instead of providing more input?
I want to pick up the one about, we've given examples of things that happen in community and primary care, and how do we think it might translate into regional tertiary care. We've done just one piece of work with people with chronic fatigue at ME, and I talked about their campaign for the service, and they did things for people, for patients who were tired of being tired, so that's what they went on to do. But there was this is not our example, this is an example from another place. So there was this just fantastic example of operating in liminal space in an acute setting from Kingston Hospital. And the problem that they were trying to deal with was that people were dehydrated, patients were dehydrated on the wards, older people were dying, and there'd been a Staffordshire inquiry. So it was about how do we tackle this? And they launched something called More Than a Lemon. So the volunteers, the champions, got lots and lots of lemons, a big bag of ice, and they went around the wards and they made cocktails. So I'm really happy to have a cocktail with somebody, but do I want to drink something out of an orange plastic cup? No, I don't. That is not going to encourage me to drink water. But a person coming around, socially together, connected, in conversation, humour, people laughing. So when patients came to fill out their friends and family survey, you can imagine what they ticked. People said, it's like the Hilton here. So it didn't matter whether the clinical care was good or not. They felt like they were being cared for. They had cocktails on the ward. So people were drinking water. And I think it's about thinking about how do we come up with solutions in liminal space. And that was a situation where staff on the wards were really busy. I mean, there was one about how do we do this when we're really busy with other things. I think you invite people to come forward to respond to the problem, which is we're really busy. So I think if you put that to people, and that's what happens in general practice. The general practice are incredibly busy. They're on their knees, and they have found a way to work together. So I think there is a place where you can work together within a service that is really, really stretched. And I think it's about seeing the people in your team also as bringing resource and resourcefulness. So it might be the receptionists, it might be some of the junior staff, it might be some of the cleaning staff, it might be people that actually can connect with other people who you work with, and seeing all of the resource within your team, not some of it, not just some of it. And I think that's where it's different. What next?
Any of those?
There's a couple still up on the board that aren't on the screen around. And again, when citizens gift their time, you talk about collecting data in clinics, the blue tech data and that kind of stuff. Work out the solutions with them. What are better ways of collecting the data? Oh, Clinics Jam collecting blue tech data. Has anybody got some personal questions to ask?
Microphones at the back if they want it. No, do you want to pick another one?
Yeah, I mean, if I pick the one at the bottom, identifying the vulnerable patients who won't self-refer. I think it's not about, I mean, I think our experience is it's not about one thing works, but you could offer different things. You don't have to have one method of doing things. So we are different. I mean, we're working in a complex adaptive system. We're working, the problems that we're dealing with, as soon as we're working together with people, they're wicked problems. One solution is not going to be the answer. So it might be that there are appointments, we ask people, how does it work for them? We had some really interesting conversations about follow-ups, and one of my colleagues has MS, and I asked her, and she said she likes the reassurance of having a follow-up, that she knows that it's there, and that's something that for her that works. But we could ask people, what matters to you? What would make more sense? And I think there's something around seeing people uniquely. And our belief is that you would see less people, and but they might want to do other things. They might want to connect into other things. Have we done them all?
There's 5 questions. Those on the board haven't been answered.
Have I not done them?
Unless you haven't done the top ones, that one.
Have I done clinical jam, collecting data? Yeah, I mean, I think when clinics are busy, you involve people in asking. The next one. I don't know. I mean, that one, I guess that seems to me to be a system issue if you're being encouraged to discharge people. And I suppose it's about, for us, it would be about being in conversation with the commissioners who are requiring you to do that if you don't think that that's appropriate. I don't know if that's a national issue or a local issue, but I think it's about making sure that we're in the conversations with the right people to try to resolve that. And our experience of working with the NHS England team are that they're people who are working really hard to do the right thing. And I think it's about working out with people together what could happen differently. Can we buddy up GPs and secondary care, acute specialists? They need to see how it is for others to gain mutual respect. We're big fans of that. We're really interested in people experiencing how it is for other people, and having those sorts of relationships and connections. And I think that the work that we're doing some work in Leeds, and we did some work with Imperial, once people get to know each other, then things happen so much better. The work that happens through the MDTs, when a GP can ring a consultant and have a question answered really quickly, might avoid a secondary referral. But people need to be in relationship in order to be able to do that. So we've just seen, just by people coming together around the things that matter to them, we could see huge advantages in that. How do you get it? I don't know what the acronyms are.
DMT stands for disease-modifying therapy. For patients on DMT, how do we get around the requirement for an annual ED? Where's Dr. Dobson? Where's Ruth? Ruth's going to make a comment about this. Come on, Ruth. You need some. This is not very personal, is it?
No, it's good. It's good.
So Ruth's going to answer that question for you.
So I think what Gavin wants me to answer the question by saying is to do, you can get patients to self-monitor their EDSS and actually feed that in as part of their annual assessment, and actually for people to be empowered to do their own assessments and take ownership of their data.
So Hussein, you've been very quiet. Is that because this is quite new dance? So you want to make a comment about self-monitoring, Hussein?
One way. And I think I was quite taken back, keep hearing about self-referral. Certainly the group of patients, people we look after from cognitive point of view, there will be difficulties. And in terms of monitoring, EDSS, yes, maybe some patients can actually do that better than we can as clinicians. But when it comes to Lemtrada patients, their blood results, we are so concerned about their actual safety. I am all for self-referral. You see, I was one of the first ones to create telephone clinics in our hospital. I'm the first one trying to get the virtual clinics using a video conferencing with patients. So I'm all for self-referral, but the group of people we look after, we have to select them carefully. Otherwise, we could end up in a lot of patients slipping the net. I know when I took over, initially, patient hadn't been seen for 40 years, and then trying to catch up with those patients of their recovery and explain to them and recover them from their downfall, it's not easy.
Does anybody else want to make a comment? Everybody's quiet. Ah, Sarah.
I don't know where Georgina is, but there are tools, I think, that you can actually try and assess who would be able and have the capacity to be able to self-refer when they need to, and who are the more vulnerable group that perhaps you would need to have a regular review with to prevent what Hussein's just mentioned about, you know, the risk of them not reporting things when they need to. So I think Georgina here, is there not something to, was it?
I wonder whether there's different ways of doing things. So one of the things that's going through my head as you're talking about people's ability to self-refer is if everybody who comes through a GP practice is self-referring, every single person. And so they make a call. Normally they will go through a switchboard, and the only option that's available to them is a clinical consultation. There's nothing else on offer. In a practice that we work in Gateshead, they make the call, they speak to either, they've segmented off those people who've got long-term conditions, and those people ring a separate telephone number. Now, you might want to segment off those people that you think are more vulnerable. When those people ring into Oxford Terrace practice, they speak to either Jane or Julie. And the call that they have is, how are you? And they begin to have a conversation, and they begin to talk about what's going on for that person. And then they might not always go through to a clinical appointment. It might be that they go to a whole range of different things. But they have reduced their attendance by 30% of that group of people because they have a conversation about what's needed. And if you think about it, it's really binary, isn't it? It's like an appointment or not. It's nothing in between. So if there was something in between, so that together, in a shared decision-making conversation, you could work out what's needed, might be the simple way to do it.
No, I mean, I absolutely agree. I think there are a lot of our patients that actually can phone the service when they think they're having a relapse, when they've got new symptoms they're not sure what to do with, and actually would go a long period of time where they're self-managing and they actually don't need to interact with us. But there are some patients that perhaps have more cognitive problems that actually wouldn't know that something needs to happen. Yeah. Or there are some patients that think, oh, well, I'm having a relapse, but I don't want steroids, without realising the importance. It's not just about treating the relapse, it's about looking at what treatment they're on and whether they need to have something different.
And what that sounds like is your data conversation, isn't it?
Exactly.
So it's about understanding your data and understanding what response we need to have to some people and what response we need to have to others. And our belief would be, once you start to really look at the data, instead of thinking of a universal group of people and then having to do one service that doesn't fit all, actually look at who they are and work out what would work best, and then test it. You know, test to see if it works. And you would always err on the side of caution.
I mean, it would certainly, you know, a lot of our neurologists they can't see a patient for a year because, you know, if they need to follow up, there isn't one available. So if you did things differently, I'm all for it. Yeah. But I think there is some tool that you can look at. Is there not, Georgina? You don't know?
Alyson, I enjoyed your session. I think you saw collaborative approach right. That's how it should be. The difficulty to patient of deciding what is important. However, I think self-referral as an example might not be the best example here.
It might not be.
And talk about GP referrals and GP self-referrals. Do you know it's 4 weeks for the patients to be seen by GPs for a self-referral? And as Sarah just said, of some of the neurologists, if they
You're right.
Yeah. But, but in a self-referral system, our patients need podiatrists and speech therapists, and they may need some physio, they may need things that are nothing, you know, and that's, I mean, self-referral will work very well in that, if you have a network of allied healthcare professionals linked up, there's no reason why your patient can't refer themselves to podiatry. Why they need to come by the MS clinical nurse specialist or the clinician to go have their toenails cut, for example.
Yeah.
You know. Anyway, I think we can go on forever.
Yeah.
I think it's...
Cocktail hour.
well, we've got to check into the hotels, and then we come back for drinks at 7. And are you going to be around this evening? So, Alyson will be around.
Thank you.
Thank you very much.